For those of you that know me or don't know me, my name is Bynum. I'm board certified pediatric dentist. Been using the device 2 Novembers ago is when I got it into my hands, and our practice has used it ever since. So I do feel that I'm a good candidate to teach this because I was one of the early adopters and had a lot of trial by fire to learn it, to teach it to others. So really happy to be here tonight, and hopefully those of you that are using it will pick up some tips tonight. Those of you who have it and don't have it out of the box yet will get brave and take it out. And those of you who don't have one will be gently pushed over the edge to call Aaron and Jordan with your credit card and purchase one. All right, so I'm like I said, pediatric dentist. I practice with my husband, Matt. He's a general dentist. We share the same space. He has half of it. I have the other half. We met in dental school on the very first day. His fiance introduced us, and that's an entirely different PowerPoint. So moving on, we did get married, and we had 3 boys, Matthew, Luke, and John. We have 2 pups. Maverick and Goose, who are Velcroed to me since I've been traveling so much. They're like PTSD that I'm always leaving. So they are literally laying on either side of me here in my dining room. They want to get some CE credit tonight, I guess. I don't know. This was our last family vacation we took together. This was last summer. We took the boys to South Africa. And so that's what I enjoy doing when I'm not in a patient's mouth or teaching. This is Matthew, this is Luke, this is John. Matthew's engaged to Maddie. They live in Florida. Luke is engaged to Faith. He's a second-year dental student at MUSC, so they are in Charleston. And John is drinking his way through Clemson. He's a junior at Clemson, and he and Sal have been dating for 4 years. And they'll probably, if I keep doing these webinars in a couple years, she'll probably have a ring on her finger as well. This is our practice. This is Holly Tree Pediatric Dentistry. Matt owns and runs Bynum Aesthetic Dentistry. And then some of you know me because I also teach courses for airway and tongue tie. So I own and run the Tot Spot of South Carolina, which frenectomies, all the things. And I always like to say on here, I'm an open book. I'm here to help you learn these products, but anything else you want to learn from NuSmile, I could probably pitch in and help, or tongue ties, or running a practice, or I know a little bit about a lot. That's what I want to say. This is my business partner. This is Megan Sharowski. She and I just celebrated the 1-year anniversary of her and I being business partners. She is also a KOL for NuSmile, and she teaches these webinars as well. And she is just as nut as I am. She's a great business partner. I encourage all of you to really, make wise decisions on who you want to go into the sunset with. It is definitely like a marriage, almost maybe even more so in some ways. And then we have an amazing team that backs us up. We don't practice in a vacuum. We have to have amazing people around us to cross the finish line and take care of all these amazing patients that want to come see us. These are the 4 doctors in our practice. Dr. Maria is weeks away from baby number 2 right there in the middle. And Dr. Nash is not pregnant, but his wife is. She's a pediatric dentist, and she is due the same time as Dr. Maria. And this is our circus. We have a very big team. We work out of one office. There's 30 of us, and it takes buy-in from all of these people to make a change or a shift like this in your practice, to adopt new technology. And I just couldn't be more proud of all these nut jobs in the bottom down here who have helped bring this technology into our practice in a way that wasn't disruptive to our patients and families. All right, back on track. We're going to talk about intraosseous anesthesia tonight. Most important thing is people want to know, how do these devices work? And when I sat in my first webinar, I thought the same thing, what is this going to be? How is this going to be any different than what I'm already doing? It sounds like just an expensive way to give a shot. Here's the difference. We're actually just completely bypassing all that soft tissue and all that guessing of getting down to the nerve. We're going straight to the nerve. We are going to the apex of the tooth. That is the target with these devices. The other thing is when we're giving our traditional injections, we think we're giving it at a steady cadence, and we are really not. Our hands are really not as great as we think they are, and every time that we push just a little bit more with a traditional syringe, we're causing a high increase in acid and a high increase in pressure, and that hurts. That's what makes our patients uncomfortable. When we're using devices that are basically little tiny computers, we are now giving an electronic injection, and this is steady. The machine takes over for us, and this decreases the discomfort our patients could potentially feel. What benefits are there to the patient? Well, we kind of already said, obviously more comfortable, but here's a big one right here is collateral numbness. Now, we don't see this in adults so much when we give injections, but with kids, a chewed up lip is usually the number one thing we're worried about. When we call to check on our patients at night, we don't want to get the calls or parents calling us saying, he's allergic to the anesthetic, when we all know we've, been through dental school and we know exactly what this is. This is a unilateral numbness where we most likely gave a block or a heavy infiltration, and now the poor kid has chewed up their lip. And this is non-existent when you use these devices that we're talking about tonight. And no need to give a block. There's no longer a need to be fishing around back at the ramus, crossing our fingers and saying little prayers, hoping that we get the patient numb with our block. Because Malamed says once the needle penetrates the skin, we're all giving a blind injection. You can think you're much better than me. I can think I'm better than you. But at the point that the needle is hidden from our view, we're all giving a blind injection.
Playing jazz.
Playing jazz.
Smoothie.
Making smoothie.
Calendar.
No meetings today. Remember, tandläkare at 9:30.
Fire off.
Fire off.
Open door.
Door open.
Så ska vi sätta en till.
Fire. Open door.
Wrong voice command.
Open door.
Wrong voice command.
Open. Open door.
Repeat back.
Open door.
I didn't understand that.
Hey, open door.
Play on the floor.
Sing on the floor.
Get on the door. Open the door.
Ever.
Hey, we're around. Open door. Open.
You're really
Fire.
here.
The truth in all of that, as I watch that video, is I think that is what our patients experienced before we had these devices. Not only was their lip numb, but their tongue was numb. And these were kids that, parents weren't taking back to school. Parents were laying out the whole day of work because they had to keep an eye on their kid. Now think about this. You can do dentistry and you can send the kid back to school. You don't have to worry about them biting their lip or their tongue. And also you can, they can grab McDonald's or Chick-fil-A on the way back and eat and you don't have to worry about them hurting themselves. So, as a mom, I'm trying to think of, and as a person who has a job, I'm thinking, gosh, this helps everybody in the long run. So less fear of the needle or the syringe. That's another great thing because these devices don't look like traditional syringes. Coined from Larry Johnson, we like to say we're taking the tooth's temperature because it looks like just a long temperature stick. They both kind of look like that. And nobody likes the needle. Just, I had blood drawn this morning and she said, I just hate this so much. Little pinch. Lady, don't tell me little pinch before you do it. I don't want to know about it. And, there is nothing really, we don't really have to worry about hiding anything from patients with this because it just doesn't look scary. So the benefits to the dentist, this maneuver right here in this picture, constantly pushing on that plunger and retracting that plunger. I I mean, I do 10 ops a day and I've practiced for almost 30 years. How many times have I done that? That is wear and tear on your hands. And your hands are your, that's what we have to practice is our hands to stay healthy. So this is taking a lot of stress off of the manual movement of giving a traditional injection. You're literally holding it like a pen. It numbs the patient immediately. So that's the two biggest things for the patient, no collateral numbness, and it numbs the patient immediately. Not really sure why they're taking out this premolar in this photo. That's another question that pops in my head on this picture. But the cool part is you can set these, set the sewing or the Sleeper 1.5 down as soon as you're done numbing the patient, and you can pick up your elevator, your forceps, your handpiece, anything. I trained residents at Lackland Air Force Base, some endo residents and some pedo residents. Aaron and I went down there, and they're insane. They're devils, and they had endo ice out, and they were numbing each other and checking to make sure teeth were numb with endo ice. Now, if you've ever had endo ice on a tooth that is has a live nerve, that don't feel good, y'all. So I do believe that we are providing very proficient numbness to our patients immediately. You can get more efficient treatment planning done. I would routinely look at a set of bite wings like this and go, okay, that's 4 appointments. That's, 4 30-minute appointments in my practice. But now I can look at this and say, oh my gosh, I could probably get I could get a half a mouth done. I could maybe get 3 quads done. So it starts to shift your thinking. You can think differently and more efficiently, and that's better for your patient and for your business practice. Less anxious patient, less anxious dentist, right? If we didn't lose the kid on the shot, we got a much better chance of getting that pulp and crown completed. So this is Dr. Megan in our practice, and parents don't come in the room for treatments. We have windows they can sit at. This grandma, she's sitting at the window, she could care less. She trusts us. She knows her granddaughter's in good hands. The other thing is we have Sean in there holding the patient's hands because we had in the notes that this patient's been anxious in the past. So we were a little nervous about that. So we had an extra set of hands on deck, but watch this. I got the eye of the Now, I don't know about y'all, but if I read the notes that it was an anxious child and I was going to have to go in and do a bunch of dentistry, that changes our physical chemistry when we get stressed out about going in to see patients over and over and over again. We think it doesn't, but it does. To go into a treatment like this is so refreshing. To have a kid that is not nervous and scared while she's getting her temperature taken on her tooth, her grandma's completely checked out back there, and if they were into giving Google reviews, this would probably be a really great one. So where have these devices been all the time? Why are we just getting our hands on them in the last couple of years? And they've been around in other countries for a really long time. There have been millions of injections given with them in over 30 countries. There's over 10,000 practitioners trained outside of the U.S., lectures given all around the world, internationally outside of the U.S., and lots of training courses as well. And it's really NuSmile that we can thank for bringing this across the border, bringing it into the United States, because it takes lots of FDA approval to get something like this through in our country. And it takes time, and it takes money, and it takes relationships, and NuSmile has gone to bat to do that for us. So how this happened, this technology was developed by a company called Dental High Tech, and these were their initial 5 trainers. These 5 trainers have gone around the world training everybody below them. It's like a spider web effect. Somebody else learns it and they teach it to somebody else. And I was very fortunate to be on the front end of the people who were taught how to use these devices in the United States when it first launched here. So myself, Dr. Josh Solomon, Dr. Megan and Dr. Miranda, we are now the forefront helping with this technology. We're teaching the webinars. You have all of our information. You can reach out to any of us at any time for any troubleshooting or questions you might have. So continue to see us helping spread the word with NuSmile and NuSmileTech with this technology. These are all the other people that are involved with dental high tech, and these are instructors that help teach for NuSmile, NuSmileTech. They help teach the Restore courses. They help teach webinars, hands-on. You'll see them at AAPD. These are the faces of the future here at NuSmile. And this is where everybody lives. Poor Josh is way over there on the West Coast by himself. But if you're on this call and you look and go, oh my gosh, I live near Garland, Texas, and that's where Dr. Sarah is. Maybe she's somebody you want to go visit. Maybe you want to go to her practice one day and watch her use the devices. Or maybe you're up in Canada. You can talk to Sarah Werb up there. So this was the relationship. Dental High Tech founded and developed the devices. They partnered with NuSmile in the United States. NuSmile then developed a new portion of the company called NuSmileTech, because NuSmile really focuses on materials and NuSmileTech focuses on technology. Dental equipment through the years, pretty shady. That's what x-rays have evolved into. Dental chairs through the years, pretty shady. Much better looking today. Anesthetic syringe through the years, not much prettier, not much different, right? So it has not only evolved, it is here with us now. This is what they look like. Like I said, they're very, they're not very scary looking. They do look like you're taking a temperature. And there's two separate devices. We're going to kind of talk through both of them. But so where do you get them? NuSmile and NuSmileTech, they are proprietary to NuSmile. So if you want them, you can't call Benco. You can't get a better deal with Darby. They're going to be coming straight from NuSmile and NuSmileTech if you'd like to get them. And just as a reminder, these are the products that NuSmile has gone to bat for pediatric dentistry. You can look at lots of other companies and they make lots of other products, but I'm super proud to say that I'm helping out a company that really focuses on pediatric dentists. They don't try to put us in the same mold as general dentists or any other specialty. When they're making a product, they're thinking about us. They're thinking about our schedule, our profit margin, our demands, and I just am really proud to say that even before I was involved in any of this, I've been using a lot of their products for a lot of years. And it's just nice to have a dental company in our corner, I feel like. So this is what they look like. One has a cord, one does not. And when people are deciding if they'd like to purchase them, this is a great slide for me to kind of talk you through that. The lights tell you a lot about the unit. They're going to communicate to you. With the Sleeper 1.5, the light goes all the way around the unit. So you're not having to cock your neck to look on one side of it to see the lights. Whereas with the Soin, the lights are only on one side of the device. So you have to get either really good at turning the device so that your eyes can line up with the lights, or ask your assistant to look at the lights, or crick your neck to look at the lights. So that is one big thing. If you want to see the lights, the Sleeper 1.5 may be your better option. The other thing is the Soin is way more complicated of a computer. Someone can be touching it too much, hitting the pedal wrong, doing things, and it can completely change the settings on it. It is a much more robust computer system inside of it, whereas the Sleeper 1.5 is like a dummy unit. You literally plug it in and put your foot on the pedal and run it. So if you are, say, in a practice with a lot of doctors or in a residency program, the Sleeper 1.5 is, often a better choice. I don't like things with cords. So I'm on the limb. The first thing I bought was the Soin because I didn't want cords. I wanted a cordless unit. In my hand, they both feel the same. As far as weight, cost-wise, the Sleeper 1.5 is a few $100s less. But again, I don't want that cord. I don't like the cord going over the patient. I don't like the chance of the patient pulling on the cord. I don't want to unplug it to take it room to room. I like to grab it and go. So you just have to, they're both great devices. Now, as our practice has grown and we've used the devices more, we now have 3 sew-ins and we have a sleeper 1.5. And I would go, when I go into a treatment room, like they live in their own treatment rooms now. So treatment room 4 is where the sleeper 1.5 lives. If I get called into treatment 4 to do a treatment, I'm not like, oh my God, the sleeper 1's in here. I don't want it. It doesn't even bother me anymore. But making your first purchase, I would be discretionary about which one you think you're going to like the best. I kind of already went through this. One has a wire, one doesn't. One's a little bit less expensive. The containers that hold the anesthetic are, the sew-in's longer, the sleeper 1.5 is shorter. You do have to get a good eye for what they look like, because when they go through sterilization together, you're like, oh my God, which room does this go in? But anyways, that is the differences again. And this is just showing you what the containers look like. I think you get 5 of them, right, Jordan? You got 5 with the unit. And they last a really long time. They cost about $30 each, but like I said, you're going to get 5 of them. You just sterilize them. Don't throw them away. Don't let your steri people trash them, because that's $30 every time. It says they have a lifespan of 50 cycles. That's just what the company's going to tell you, but you can definitely push that limit. It's when the threads down at the bottom start to give way that you want to get rid of them. But when you're just seeing like craze lines in them, they're still resolute. You can still use them. And they will kind of change color over time as well. And they show the haziness and the cracking in them. All right, so let's get into how do these devices work. This would be how you would give a traditional injection. You'd inject into the tissue, pray to God, it goes through the bone, gets to the nerve of the tooth, and you can see that all that anesthetic is diffusing quickly, even with epinephrine involved. It's going to penetrate through all that soft tissue, and hopefully some of it goes through the bone and gets to the nerve of the tooth. When we use these devices, it's much more, it's held at the target a lot better. It doesn't diffuse as quickly, and it's going to hit the target because it's not just floating around in the soft tissue. So before I show this video, you're going to see that there are 2 injections. The first injection is going to be to numb the tissue and the periosteum. It's a very short injection, and you just want to see the tissue blanch. Take the needle out, and you're going to redirect in a completely different plane for your second injection, which is going to be your intraosseous injection. Like I said, that first injection is just to get that initial numbness going, and then you're going to see the second injection. First injection, you sort of just like lay it into the tissue. It's all pedal driven. We're going to show the pedal here in a minute. We're numbing that papilla right there. Second injection, you're coming more from the top. You're trying to come into the most hollow cancellous bone you can find, and that's going to be at the top, at the peak of that bone right there. You punch through, put your foot on the pedal, and inject the intraosseous portion. And it shows how it spreads out through that bone and into the nerve and to your tooth. When we are injecting in the maxilla, we can confidently know that we're going to get profound anesthesia, 2 teeth back and 2 teeth forward. When we're numbing in the mandible, not so much. We can confidently know we're going to get 1 tooth back and 2 teeth forward. So that's sort of just a rule of thumb. Maxillary, 2 back, 2 forward. Mandible, 1 back, 2 forward. But you also have to think about your patient, right? Like if it's a 4-year-old with a primary dentition, that anesthetic probably is going to travel further than a 12-year-old who's playing varsity linebacker, right? So you got to read the room. You got to know like what kind of bone you're working with. So this would just be an example. You're going between these two primary molars. That is what you would expect to be profoundly numb. If we go in the anterior, you can get it canine to canine. You can numb canine to canine. So you could, and you can see all that blanching right there. You can get your injection done and go straight to work, whatever you're going to do right there. Same thing in the mandible, canine to canine, maybe a little bit further. Why is there minimal to any discomfort? And the reason is we're using a special needle that we're going to talk about here in a minute. We're giving the injection electronically, like we talked about. That helps with discomfort. And we're also using really good support points. So we're not just floating out in space with these devices. You have to have, good support points when you're doing this. So this is what a standard needle would look like under an SEM. It literally tears through the tissue. Whereas with these needles, they're called Effitech needles, and they have a double bevel on them, and they act more like a scalpel. So that's why if this is your hand, you're like laying the needle into it. You're not sliding it under like this or poking it into the patient. You're laying it on there, and because it is like a scalpel, it just like goes into the skin like butter. It literally does. I've done it on my hand half a dozen times already, and you don't even feel it. So here's the approach. Like I said, we're just literally just sliding it right under that tissue, giving that initial injection. It's a very shallow injection. So these would be the differences in your needles. Like I said, one's like a scalpel, traditional needle punctures or tears the tissue. We really recommend, in pedo, we don't need much more than a 9mm 30 gauge extra short to get the job done. The cost gets asked a lot. You're looking at about 10 cents more per needle to use the Effitech and to be more compassionate to your patients. So it is a 3-stage approach. We kind of saw it in that video. The first injection is going to be to numb the mucosal and that periosteal area. The second part is going to be penetrating into the bone. And then the third part is going to be delivering the anesthetic. So it is a 3-stage technique. When we're going to do stage 1, we're going to use this inner pedal right here. Think of the papilla is tiny, and so we're going to use that tiny pedal right there. That's what we're going to step on to give that initial injection. And then the initial injection, this is literally how slow it's going. When I taught this weekend, people were like, it's not working, the plunger's not moving. I'm like, oh yes, sis, it's moving. It's just moving really slow. D, there's a letter D. I don't know if you've seen it to this point or paid attention to it, but there's a D on the hub of these needles. And the D is there, it stands for dental high tech, and it's there to tell you to get the right orientation of that scalpel edge of that needle. So the D needs to always be pointing out. It needs to be pointing to the facial or the buccal for the first injection. For the second injection, it doesn't matter because the tissue's already numb. So it doesn't matter what angle or orientation you're using the needle in the second time. So these are just some photos showing how you're just, the D's pointing out and you're just laying the needle into the tissue. Little video of it. Just so superficial, barely underneath the mucosa. If you're not in and you step on the pedal, you're going to see anesthetic like flowing out of there and you're going to be like, oh, I'm not in, I need to go in a little bit more. This is in our practice. Again, this is just showing how you just sort of lay it into the tissue. Another one over here. Have that suction in there because she likes to dribble. With all of this, y'all, there's definitely a learning curve, but I promise you, you're going to get to the point where your patients aren't feeling this at all. And we're going to talk about it later, but using topical, I'm totally away from topical now. I feel like I'm off my learning curve. I can give this first injection with no discomfort whatsoever. Also have your assistant in there being a distracting component of this. You see they're in there with their suctions like tapping. If you weren't doing that before, that's a big hack right there, is to have your assistant creating a secondary distraction. So we got the first injection done. Now the second part, we got to get through that bone. And then we're going to deliver the anesthetic. This is the rate it goes for round 2 when we're in the bone. It is a higher cadence, but again, that plunger is moving ever so slightly. So we're on the outside pedal for the IO portion. You can step on either side of it, it doesn't matter. When I learned this, I was taught that you're gonna feel this sensation of punching through the bone like you would through an eggshell or a milk carton. And that is not always the case. Now, if you feel that, you can be 100% confident you're in the bone, but a lot of times you're not gonna feel that. And the analogy I use is a stainless steel crown, right? When you're placing a stainless steel crown, if it snaps on, you know, you're 100% confident that that is the right size and it fits, but you don't always get that snap, right? Sometimes you have to play with it and get your how out and twist it and push on it and check it. And so you have other tools in your toolbox to figure out if the crown fit. Same thing with this. If you get the pop, 100% you're in, but we have some other tools that we can share with you to make sure that you're confident that you're into the bone. And we'll talk about those here in a little bit. So this is the second injection, almost like a straight up and down angle going in. You see the hands are very, very close to the, very choked up on the device. All right, moving on. So this will be those patients you saw earlier getting the mucosal injection, they're not going to get the IO. So here's Dr. Nash. Giving it a little twist to help it. You're kind of like guiding it and kind of giving it a little pressure as you twist. And then I don't know if you could see right there, but he sort of like tugged back. That's a really good hack to see if it's in. The lights are telling you that, you don't have too much pressure. If it gets up to 4 lights, it's too much pressure. You're in too far. Let's cut this video. See, I'm tugging back on it. That's me giving that injection. And I'm tugging on it. So if you just tug a little bit and it doesn't come with you, you're in the bone. Step on the pedal. You're good to go. This is my mouth. I really want to skip this so bad, but I'm going to show you anyways. It's only for kids, 12 to 14. Is it 12 or 14, Jordan?
We say 14 and under.
Yeah, 14 and under. I'm not 14. But I wanted Megan I had to get a crown. I was in a temporary. Did you see her pop in right there? She worked on that for 20 seconds before she got it in, but she was patient and she kept twisting. And as the patient, you don't feel any of that. Like you don't even know that's happening. So definitely I would say patience is a big tool you need to bring with you on this learning curve as you're learning this new technology is be patient. Are radiographs important? Extremely important. We're so used to looking at radiographs to treatment plan a carious lesion. Now we have to look at the bone, because if we're not looking at the bone and finding good bone, we can't give an intraosseous injection. So let's look right here down in the bottom. We've got these 3 teeth we need to treat. Obviously, we don't have great bone around the primary teeth, but we got a nice chunk right between 19 and K. We can inject right there. That's going to numb that permanent molar. We can fix it, and we can take out those 2 baby teeth, which is what I hope this person is planning to do. Here again, okay, we're looking at the bite wing. We're like, oh man, there's no bone between those 2 molars right there. Well, pull out your pano. It's just a different angle. So get in the habit of like pulling past x-rays to look for good bone. And just finding sweet spots of bone. There's a good spot. There's bone right there. And this was the one we just showed earlier. that's a random bite piano in there. I don't even know why that's there. That's weird. All right, so here's some anterior teeth. One thing I really want you to appreciate here is the bleeding. I can't explain all of that, but when you do an extraction or you prep around a tooth for a crown, you get minimal bleeding when you use these devices as well. So lot easier cleanup, lot less chance for pink crowns when you're done. This was a half a carpule. This is a hot tooth right here that Dr. Lorianne treated, and she found a really good chunk of bone distal to the tooth. You're going to see her drop in. I think that's the first injection. Let's get through that. Second one pops in the bone. Now I'm showing this because people really challenge and are unsure if the palate's going to be numb. I promise you the palate's going to be numb. And this is what I would call like a hot tooth probably. She is all up in there, all in that palate, getting that tooth out. This is a patient in our practice again. Just showing, I mean, it is a steep angle that you're working with, and it is odd to hold it that way. And again, it's just something different, but you will get it. This was Dr. Nash's first IV day when we exposed him to using the device. He'd practiced 3 years in another practice. So if you have IV cases, sedation cases, those are great patients to practice on because it does help with heme control. And you can use those patients to really learn on. So he's leaning the needle in. And then going in for the second extraction or second injection. And after you're done here and you extract those 4 front teeth, they hardly bleed at all. So I put this back in here because I just wanted you to see that I am looking at that radiograph. I'm looking here in between these 2 teeth to make sure that I have good bone before I start that second injection over there. Here's another example. I'm going to look at my radiograph closely, find a good palette of bone to go into or a good place to go into. Another one. Got a big old nasty abscess back there. We've got to get A out. So we were able to find some bone between A and B. Twisting, popped in. All right. So again, we no longer have to hold syringes like this. We can be up close and hold it like a pen. All right, let's talk about some final things here. Onset is immediate. The recommendation is to use articaine or septicaine. I think we all know this anyways, that when you're giving an IO injection, articaine, septicaine, same thing, is the standard of care. It does have a different chemistry to it than lidocaine, so it is going to penetrate through those, through the cortical plate and through the bone better. If we use 1 to 200, we're going to get about 30 to 45 minutes of working time. If we do 1 to 100, we up our duration. We can work longer, but you do, a couple things here. You do have a higher chance of an ischemia when you have it more or less diluted. The second thing is, do we really need a kid numb for 60 minutes? We probably don't. I'd rather err and be more conservative and do the 1 to 200. And then if I need more anesthetic, if it's wearing off, I can always go back in and give more. And the other thing is, I don't want both of these carpules rolling around in my treatment rooms. I want to know that when my team picks up a carpule, it's always 1 to 200. I don't want to have to think about what's getting loaded. So how to be effective? 4 principles. Use the most appropriate anesthetic solution. We just said use the septo. Give the right amount. Be gentle and take your time. Patience is definitely going to be needed. And make sure you're as close to the target as possible. So what else are you not thinking about to ask? We get asked this all the time. Why does it go so slow? Because when you're sitting there using it, you're like, I don't have time to buy these devices and use these devices. Like, this is cutting into my time. It's going too slow. So I want to show you some examples of having it go slow, but it's really benefiting you and your patient. So this patient right here.
Do you want NuSmileTech too?
Probably not.
She's using topical. She's going to do a filling and she's going to do 2 extractions. This is Dr. Megan. She's giving the injections or injection. We're going to move along here. She's probably in stage 2 right now. And you're like, oh my God, that's so long. Taking so long. Well, now she's got her isolite in there. She's doing a filling. She's going to fill the whole tooth. Finish filling it. And pull 2 teeth. And y'all, she's done in 7.5 minutes. She never got up from the chair. Now let's say that she needed to get up from the chair. Let's say there were 2 recalls ready. Fine, go check the recalls and come back. But if you're not up against recalls and you can stay in the room, look at that, look at that, look at that. No bleeding. That's what the sockets look like afterwards. So 7.5 minutes, start to finish. And that gives you, if you're running 30-minute ops, now you have 20 minutes and some change left over for your team to turn the room over, maybe work in another treatment. Hell, you could work in 2 more treatments if you wanted to, if they were each going to be 7 minutes. Here's another one. This is Dr. Nash last week, taking out a premolar for ortho.
Nice and big for me. Thank you.
So again, we're going to run through this. See the assistant distracting? So we get all that done. Mouth molten. Tooth on its way out. Maybe. Okay, it's out. So here he is afterwards, sitting up in the chair. 6 minutes and 51 seconds. Done with an entire treatment. So I think we can all agree that we can sit there for 2.5 minutes and listen to one Frozen song while we give the injection if it provides us the opportunity to get our patients out of the chair faster. And let's just think about a patient with anxiety. Obviously, these kids are great kids, but how much more compassionate is it to get the scared kid out of the chair faster, right? So here's one for you. This is a 2 or 3-year-old that needs extractions done, right? There's no reasoning with this kid at this point. It has to be done. It's a hold and go. That's the mom in there helping. And it sucks. It sucks for the kid, it sucks for the mom, and it definitely sucks for us. But if we could cut the suckage time down, wouldn't that be great? Oh, hey. So we're given the injections, the first and the second. Little fella, how do you feel about this? Not good, not good. So we'll get that part done. Second part. Still the second part. Feels like forever. We're a minute and a half in. Kid's just pissed. He doesn't even have a tear. He's just mad. But y'all, look how awesome. Look how awesome. That was done in 2 minutes and 5 seconds. That is so much better than numbing a patient, letting the patient sit up, get a sip of water, hug on their mom. They think it's done, and that was just the appetizer. You got to lay them back down for the main course to get the tooth out. This was done in 2 minutes and 5 seconds. Is there anything else like it on the market? There's a lot of different things like it, but there's nothing just like it. There's nothing that will do everything that this device will do. These devices. Hypoplastic 6-year-old molars, no longer a problem. So easy to get these teeth numb. They cooperate when you give anesthetic this way. So no longer do you have to give 2 carpules of septo and maybe bring the patient back and just all kinds of stressful situations. Statistically, studies show that if you infiltrated one of these teeth, you'd get it numb about 25% of the time, whereas if you gave an IO injection, you'd get it numb about 90% of the time. But if you're using an IO device that also provides the right cadence, which is what these devices do, it's probably higher than that. It's probably higher than this 90%. Topical, that's your choice. I would say definitely use it while you're learning the devices. Don't change anything. Just keep doing everything the way you normally would. I just stopped using it now because I feel like it's one more step. I'm very impatient. So when I come in a room, I don't use it. But, just sticking a Q-tip in a kid's mouth is a pretty good little litmus test to find out if they're going to be crazy or not, right? You don't know if they're going to go off the rails. If they go off the rails with a Q-tip, they're going to go off the rails the entire time. So a 7-minute appointment would probably be a lot better than a 30-minute appointment of them being crazy. What size needle? I kind of touched on this, but really we all recommend using extra shorts. You're going to have way less chance of bending these needles as you're trying to penetrate that bone. The shorter the needle is. The longer the needle is, the more chance it's going to wobble and bend on you. How much anesthetic should you give? It depends. It's complicated. Size and age of the patient. How many teeth do we have to work on at this visit? What treatment are you doing on the teeth? Is it going to be an occlusal or is it going to be 2 extractions? And how much time do you need to get the appointment done, right? Somebody fresh out of school or just learning may take a little bit more time than someone who's been doing it a while. No more needs for palatal injections, no more need for blocks. The learning curve, I would tell you, we tell everybody Set yourself up for success. Start in the primary dentition. Don't start with the bigger kids. Don't start with a behavior management kid. Start with a good kid in the primary dentition as you're learning how to use the devices. You're going to bend needles. It's going to happen. I still bend needles. I get sidetracked or I'm looking away and I bend a needle. But the needles are going to bend long before they're going to break. Breaking needles just super rare, just rarely happens. You're going to, like I said, you're going to bend it. The integrity of the needle is going to wear out by bending long before it's going to break. And then picking your injection site, that is a learning curve to figure out where you want to inject. And getting a good grip on the device. Getting down, the lower you get, the closer you get to the hub, the more control you have when you give that injection. So why do you need it? Remember, immediate action of the anesthetic, predictable anesthesia. Hypoplastic sixes are no longer unpredictable. No delay. You can choose to have the appointment done in the 7 minutes like we showed you, or you can go check a bay full of recalls if you want. Way less stress on everybody. Literally no post-op side effects. Now, when you're learning this, will your patients be a little sore as you're gouging them with a needle to figure it out? They probably will. Start practicing on your team. Let them practice on them and let them see what it's like, or let another doctor practice on you so you can see what it's like. It's going to optimize your appointments. Like I said, you can just, probably every day now we work in 2 to 5 ops a day, same day treatment, because we can. And for no other reason, your practice image. Market the heck out of these things that you're doing something different. You have something new, a new technology that's more passionate and better for kids. I remember when lasers first came out, that's what everybody did. Everybody bought their lasers to, show that we're trying to take better care of our kids. And Luke, being a second-year dental student, this was at Thanksgiving. He's now practiced on a bunch of people, but he practiced on his brother. If a non-dentist yet sitting in my dining room can learn how to do this and get his brother numb, and if someone old like me can figure it out, all of you on this call tonight can figure it out. The other thing is, we don't have an option in our practice. These are our 4 doctors. There are no traditional syringes. If you came to my office tomorrow, there are no traditional syringes in any of the treatment rooms. It's these devices or nothing. If there was going to be a problem, one of these people would be in my ear by now saying, we need some backup. It's, sometimes it doesn't work. I think they're feeling it. I've got 4 incredible doctors, all 4 of us, and this is all we use. So having this backup system, or one doctor doesn't want to use it, that's just, you got to debunk that. I had a doctor this weekend at Pearls, and her associate doesn't want to use it. And I said, you go back this weekend and you say, this is better for our patients. It's time for you to learn to use the device. And another reason you don't need it, you don't have to give inferior alveolars anymore.
Papa, you come to train.
Because that's about what it feels like for the patient and for you when you're jabbing back there into the dark, hoping to get profound anesthesia for the patient. What do they cost? They're not too bad. $29.50 for the sewing. And we've got $2,700 for the Sleeper 1.5. The more you buy, the better discounts you get. So if you buy 3, the price goes down, obviously, on both of them. And this is what you get. You get the foot pedal, you get a holder. If you buy the Sleeper 1.5, you get the holder for it. You get all the containers. You get 2 boxes of needles. You get some goodies. How are you going to learn it? You can listen to webinars like this. They're all posted online. There's master webinars, beginner webinars, lots of great questions on the webinars, but there's training available. Chris Malzone is a great trainer. This is his info. We have Jordan on here as well. Jordan and I are going to snap a photo together in Denver so I can put it in the webinar.
Chicago.
That's right. We're in Chicago in May. We'll do it then. So great trainers, great troubleshooters. You can text them, you can email them. They are fully accessible. And then we have Erin, excellent trainer. She will also be, Erin, you do all the onboarding, correct?
Not anymore. Jordan, that's all right. Now that Jordan, now that we kind of split the country, so I'm West Coast and Jordan's East Coast, Jordan's kind of getting back into the onboardings and stuff.
Okay.
So we're splitting them up.
Well, great. So again, just my point is these are great people. They want to see you be successful. They don't want to see you fumbling around. They don't want to see it left in the box. That doesn't look good for their company. They want to see us be successful with these devices. So you got to reach out. You can't be like, I'm a doctor and I should know how to do this. No, you should know how to do this. You haven't been trained in this yet. So how will we all get to learn it? This is how I learned it, is with Dr. Prin. He came over from the UK and he trained our office. And this was the first day that we learned how to use the devices. We used it on 10, 15 patients that day between all of us. And he provided a stab lab. We did training. If you have big groups, reach out to Erin and Jordan. They can a lot of times accommodate that. I'm talking to a very large group, 150 doctors and team members, to train them on the devices here shortly. So, it can't hurt to reach out and ask to do some in-person stuff, or they could jump on a webinar and train, jump on a Zoom or a Teams and help you as well. So lots of different modalities to learn by. This was our stab lab. Bunch of dentists using it on each other is always hilarious. Join the Facebook group. This is a great, even if you don't have the devices yet, jump in here, learn a lot. I learn a lot every day. The way we learn in this group is people post what's not working. When you post what's not working, that's how we all learn together to figure out how to get it to work for you. So jump in here, learn a lot, make some new friends who have the devices. You might find somebody who's close to you that has it, and you can go shadow and see how it, how it works before you buy one. Who else is using it? Dr. Bobby Elliott, a lot of you know him. He's one of my dearest friends. He is not an early adopter. So when he finally used it, worked like a boss. I took out an upper right 4 on a 13-year-old. I took out C and H on a 7-year-old. Parents are blown away. There's your 5-star Google reviews right there, people. Thank you both for all the education. I said thank you so much for sharing a story like that, because that is social proof is what made me want to learn more about the devices. I knew Loree very well, and she was using it, and I was like, oh my God dang, if Loree's got it, I'm going to get it too. Brian Richards, big eye pedo guy, dear friend. We went to Iowa together. I just did my first sewing case. The kid broke lower anteriors. It was a trauma case. He couldn't even blow air on them. He gave half a carpule. Kid never flinched. For the beveling and the cleaning, he never felt a thing. Thank you for selling me on this. I'll be curious how appointments go tomorrow. Well, tomorrow, the next day, he doesn't have parents back, and he uses rubber dam. And he launched big time. He was doing 3 and 4-year-olds, pulps and crowns with his rubber dam. And he was like, this is amazing. I can place a rubber dam and not have to worry that the tissue's numb or not. Meredith, she's in my home state of South Carolina. Super averse to using it. She didn't take it out of the box for 6 months. I saw her SSPD. I was like, sis, you got to get out of the box. You got to use it. She used it last January. I did it. I numbed at 10:13. I extracted by 10:15. 2-minute appointment. 2-minute appointment. I said, can I please talk about it in the webinar when she sent it to me? And she said, yes, it was a huge rush. Dentistry can be fun and new and exciting. And in pediatric dentistry, we don't get to say that much. My husband gets to buy a new scanner or $50,000 piece of whatever every other year. And in pedo, we have SDF, we have an ISOLite or DryVac, and now we have this. I would say these are the 3 things. And this is the biggest thing for me. And it's not 50,000, it's 3,000. Wrapping it up, if you want to learn anything hands-on, included this technology or anything that has to do with any of the NuSmile products, these are the cities and the dates of their upcoming courses. I will be with Jordan in Chicago teaching in May. I will be in Charleston in June teaching there. So if you don't want to see me, go to Los Angeles or Fort Lauderdale or somewhere else. I think Dr. Megan and Dr. Brian are teaching in LA. So just a fun, make a little vacation out of it and learn something, learn these devices, learn a lot of other things, meet some cool people. Thank you, everybody, for your time and attention. And I'm here for you. I want to see you buy these devices and use these devices. They are the best thing you can do for your patients today. This is my information. Just screenshot the QR code. You can text me, you can email me, you can DM me, you can do whatever you want. That's what I got. Thank you all for listening. Any
Awesome.
questions?
Thank you, Ann. Let's get into some questions. So, Dr. Jill Shonka, I hope I said that right. I see that this is being recorded. Is it possible to get this presentation to show staff before we start implementing? Yes, absolutely. We have all of our recorded webinars on our website. This one will be recorded as well, and will be posted on the website hopefully by Friday at the latest end of the week. So.
And the other nice thing too, Jill, is that they record like all these questions at the end. The reason they don't take questions in the middle of the webinars is they want all the questions clustered at the end. So you may not need to watch every single webinar, but it is really nice to go to the end and listen to all the different questions because they're different every time.
Dr. James Hahn, he asked this, I believe, right before you got to the 6-year molar slide, but can this effectively numb hypoplastic, hypomineralized teeth? Do you want to touch on a little bit about your experience with that?
Definitely. I mean, I used to walk into a room and think it'd say 19 occlusal. Well, that could be like, I don't have to numb it at all, or it could be a bombed out hypoplastic 6-year-old molar. And now I don't even worry about it. I'm not nervous about it because it delivers profound anesthesia. So yes, the answer is yes.
Any other questions? Please ask away in the Q&A.
Jill Shonka, she bought this weekend too from Pearls. So welcome to the club.
One thing that people do sometimes ask is, can we damage a tooth bud? I think you've got way more chance of damaging tooth buds when you're sticking needles into blind spots in a kid's mouth. So this is a super short needle, 9 millimeter. You're nowhere near tooth buds. If anything, you may drop into a PDL accidentally, but we intentionally give PDLs all the time and no one's worried about tooth buds then. So this is just, I can't give you 20 studies that say you can't do this, but this is not a concern. This has been used 20 plus years in other countries and we're not ruining tooth buds with it.
Another question here, Dr. Aiden. Hello, I know you said 14 and younger, but have you had any success up to 16-year-olds? I know you showed the video of yourself, but do you want to talk about UC?
So great question. The company is going to stand behind it up to age 14. All the studies have been done up to that age with these devices. And it's basically just it's unpredictable how dense and calcified that bone is once you get into the teen years. Now, having said that, 4 doctors in my practice, we graduate patients at age 19, and we don't use traditional syringes. So we have had lots of experience in my practice and our practice using it on kids from 14 to 19. No one's pulling out a traditional syringe. I wouldn't do that as my first patient, but I would tell you it can be done because we're doing it.
Awesome. Next is Dr. Ryan Closey. For significant buccal abscesses, have you given a long palatal or lingual with success?
So great question. If you want to be fancy, you can go on the lingual. You have really great bone on the lingual. I wouldn't be giving a long palatal. I would be giving the same type of an injection that I would give on the buccal on the lingual surface. Do the same procedure. Go into the lingual papilla, give the first stage, and then give the second stage.
Awesome. Dr. Liliana Liliana Lucas. You mentioned it was mainly being used for 14 under, and just hit on that. So go to the next one. Dr. Ramia, just clarify. So the dots on the side of the sew-in, if you see 4 dots lit up, then it's too much pressure. You should retract and try again. Is that right?
Give the webinar, sis. Yes, you're 100% right. So when you see those dots, 1 to 2, you're in the safe zone. When you start to see 3 or 4, what's happening is pressure is building up and the computer is sensing that. Why is pressure building up? Could be a number of reasons. Could be you've got a piece of bone in the lumen of the needle, right? You're going to have to troubleshoot it at this point. Most of the time, it's because the anesthetic is being delivered at the rate that the device has decided, and it's pushing that anesthetic into the bone. And sometimes it's going too fast. So it's telling you, I'm feeling pressure right now. Just give it about 5 seconds, and a lot of times the computer figures it out and will drop those dots back down to 1 or 2. If it doesn't figure it out and you're still getting 3 and 4 blinking lights, your next piece of action you would take is you're going to just back off a little bit. Just try to come off that bone a little bit. That usually fixes it. If you're still like, oh my God, it's 4 dots, I don't think anything's happening, you probably have a piece of bone stuck in the needle. Take it out, put a new needle on, and go back in. Erin, you want to comment on that at all?
Yeah, one thing on that is that at 4 dots, it will stop delivering on its own so that you can't do too much pressure. So it gives you kind of that safe stop. And then just to clarify, she said you should retract and try again. Don't retract the plunger, just retract the needle from the bone.
Yeah, just like pull out a little bit.
Right. And then, if you do go to 3 or 4 lights again, that's when you might have a lumen clog or something. Then take your needle out, change out the needle, and go again. So don't retract the plunger, though, until you're done with that patient or that cart, because you can't really re-engage it.
Sure.
Thanks, Erin. That was actually really good.
Let's not look at me anymore. Let's get this off the slide.
Dr. Kelly asks, have you ever had a needle break, or if a needle breaks at the hub, what do you recommend to use to get it out of the bone?
I have never had a needle break, but this weekend at Pearls, I heard someone saying they had a needle break and that it was no big deal. They just took their hemostat because it's sitting right there. It's like it's in the bone. It's like looking at you. You just take a hemostat and pluck it out like a whisker, and then you like poop yourself for a minute, and then you put a new needle on and you do it again. And I mean, I've heard of needles breaking in an inferior alveolar, and then it's just floating in the tissue, and you're taking films and trying to find it. You're not going to have to go finding this. It's going to just be sticking there, and you're going to pull it out. But I haven't had it, but I heard someone talk about it this weekend, actually.
Dr. Eden asks, good evening. Has this device been used on patients with, I'm going to butcher this, but exostosis? Has it been harder to anesthetize?
Great question. We practiced on adults this weekend, and there was a patient who had a lot of exostosis. And you just have to, you have to know your audience, right? You have to go, okay, well, most of the time exostosis is either on the buccal or the lingual. So if you see a lot of it on the buccal, you can inject from the lingual. If the exostosis is around the tooth you need to work on, you may need to go back a few more teeth, and you may have to give more anesthetic so that it will travel further to get to the target tooth. But yes, you can use it, but it's gonna be a little biatchy to get in there probably. Because think about it. What?
Can you tell me what that is really quick? Just so I've never had this question.
Yes, exostosis is an increased amount of bone. And when people who grind or have dysfunctional habits, bone builds up around teeth to protect them.
Gotcha.
So people who are stressed out, like tori is bone underneath your tongue. That's a form of exostosis. And I will tell you that you would think, oh, a canine, that can't be too hard to do an IO injection around a canine. Canines are tough. There's a lot of thick bone around a canine. So sometimes if you're going to work on a canine, go a tooth behind it where you can penetrate the bone a lot easier.
Awesome. Great question. That was the first I've gotten that as well.
Yeah.
So, phenomenal question.
Yeah, good job saying exostosis.
Um, if you are treating a quadrant, do you have to do it in more than one area?
No. No, you don't. One and done.
Perfect. What does the beeping mean when you press the larger pedal?
When you hear beeping, it's the device is delivering anesthetic. But you're going to have your music on, you're going to have your high vacuum suction on. That beeping, you're not, most of the time, you don't hear it in my experience.
I'm
It's very
gonna
low.
jump in on this. So with the smaller foot pedal, you'll hear beeping every like 1 to 2 seconds. With the larger foot pedal, you'll hear a beep every quarter carpal of the way, but it's not going to beep like continually throughout the way like the smaller foot pedal does. But again, the beeps are very faint. So like Ann said, you're probably not really going to hear it. But if you hear it when you're using the larger foot pedal, it'll give you 1 beep at a quarter carpal, 2 beeps at a half, 3 at 3/4, if you do happen to hear it. Any post-op issues? Tissue slothing, ulcerations, prolonged numbing, or discomfort?
I've seen a good bit of it in the Sew-In Facebook group, and it most of the time comes down to you were, being pretty aggressive at the site of injection. There's been a few ischemias where the tissue just like didn't respond very well. It didn't like the anesthetic. But I think sometimes when people are calling to check on their patients, and the patient is saying, the mom's like, oh my God, he's so sore. I know people are jumping right to, oh my God, he's so sore because I used this new device and I hurt him. No, he's so sore because you did a pulp and a crown and an extraction, and that's why he's sore. Or you did 2 class 2s next to each other and you had a wedge and some bands in there. So don't just jump to the conclusion that the soreness is from this device. That you saw Megan working on me. She went to town on me and I was not sore at all. So I don't know. Yes, I think some people are going to be sore, but that should be very minimal. We call and check on all of our outpatients. No one is reporting back to me that parents are like, my kid's sore, don't ever use that again on my kid.
Aaron, you want to ask his last few?
Sure. I also want to say on that sort of thing, there's now that whole power of suggestion thing. So if you're telling parents, like, I'm using this new device, tell me how it is. Are they more, like, if you're really prompting them, but if you're just asking like you would normally ask, I think that cuts down on that a little bit too.
Yeah.
All right, Dr. Joy Dixon, if you anesthetize 2 different quadrants, should you change the needle between? How quickly does it dull?
Great question. My recommendation, let's say we're going to do 2 lower quadrants right here. My recommendation would be give stage 1 injection over here into the papilla. Give stage 1 injection over here into the papilla, because we shouldn't be damaging the needle just going through the tissue. Then come back over here, give your IO injection. If it goes smoothly, if you get into the bone, it just slides right in. You don't have any problems. You don't feel like you've done anything to damage the integrity of the needle. I would go right back over here and go again. If I had issues over here, if I feel like it bent, I struggled, I probably boogered it up a little bit, then I would probably change the needle before I gave stage 2 over here. The more I use it, the more I feel like I can push the limit of it because I've gotten better with time.
And remember, they're only 27 cents a needle. So when in doubt, change your needle. So it's not like, I think the wand's like $1 or something. You don't want to keep changing it. But with this, it's just a needle. Just be nice to your patients and change it out. Okay, Dr. Priya Devon, are there any absolute contraindications to using the Sew-In, i.e. fractured jaw? And Jordan gave the questions to me so that I would have to say this word, osteogenesis imperfecta.
We talked about osteogenesis imperfecta this weekend at the course, and I don't really think there's any contraindications to it. it may just be trial by fire, but I don't know about fractured jaws. I would think not. There are devices like these that are made for adults in other countries. We don't have them in our country, but there are IO devices used in other countries, and oral surgeons use them. They lay flaps and do all kinds of crazy stuff using these devices. So I don't think there's many limitations to them.
Okay. Dr. Priya again. Also, what happens if you inject into the abscess or an abscess? Yeah.
Well, I think I would hope that with training you wouldn't do that, because the goal is to really find good bone. And if I saw a big abscess, either clinically or on an x-ray, I'm going to stay very far away from that. If you didn't do that, if you got fooled and you put your needle in, you're going to sink into mushy abscess. So you're going to be like, I got to get out of here. So find another spot to inject into. I hope that answered the question.
I think so. Okay, Dr. Ramya, and y'all, these are great questions. I love that y'all are asking so many, because this is your time to do it, and we've already had 14, so that's great. Dr. Ramya, since anesthesia lasts 45 minutes or so, do you typically recommend that patients take Tylenol or Advil after extractions?
I recommend that anyway. So yes, our protocol is to have an NSAID on board, post extractions especially. So I would continue to give that recommendation out, not because I use the device, but because whether it wore off in 15 minutes or an hour and 15 minutes is probably still not going to feel great.
I think Dr. Lurie pre-treats or tells patients to pre-treat. I think some doctors were talking about that on the Facebook page.
Yes, and that's a personal, thing. Sometimes I don't like to do that, because then parents are like, "Oh my God, it's going to be so terrible that they want me to give pain medicine before I do it."
Yeah, it's personal. But yeah, some people were saying, I think on the Facebook group, that they were pre-treating or whatever, because it was. I think some doctors were saying, and y'all can go back and read. There's lots of good stuff on there, but that it was wearing off in the office, so they were hearing a lot more of the complaints, because it was wearing off faster and they were still there. So it wasn't hurting bad enough that they would have called you back, but it was hurting that, so they were saying it in office.
Right. Just uncomfortable.
Well, unless any questions come through, great job with all the questions tonight. Thank you so much.
Yes, thank you.
I think we're about good to go. So Anne, I appreciate you. Anything else to add, Aaron? Any closing notes?
Just that Jordan and I are always here for you guys. If y'all need anything, if you want more clarification, if you want to do an online, we can get on a Teams call and show you the device, what it looks like, how to put it together. So whatever you need to make you feel better about using it, jumping on board, just reach out and let us know.
Thank you.
Thanks,
Thank you. And remember, be on the lookout for the survey.